welcome to the Twitter space. My name is Ada. I am the community manager for One Health. Um, Thank you very much for joining the Twitter space. Yes, and we have our amazing eye doctor. So she is going to be our speaker for today. So I just sent her a request. All right. I hope everyone is having a wonderful weekend. I know that with everything that has been going on, um, things are a bit tough. So I just want to say thank you all for joining, and I hope this Twitter space is going to be an amazing experience for everyone, and we're all going to learn as many things as we possibly can. All right. So Dr. Ada, I just sent you a request to be a listener, to be a speaker. Okay, thank you very much for accepting. All right. So please just let me know when you are good to go so that we can just start.
Hi, good evening, everyone. Thank you so much for having me, Ada. I'm ready when you're ready.
All right, so I am very ready. So we're just going to get right into it. So I'm sure many of us we've heard about glaucoma. We don't. Some of us maybe we know someone who has either suffered from it or we have seen maybe things about it in the media, in movies. The first time I ever even like knew about what glaucoma was from a comedy movie. It was actually from a comedy series, and I didn't know about it until I just started working at a healthcare company, and doing my research, I just found out that okay, during the course of someone having diabetes can actually be at risk of having glaucoma, and there's a nickname for glaucoma, which is a silent sight stealer. So I'm just going to go right into it and just hand over to our doctor. So I'll just ask some questions. And please, if you have any questions, please just let us know. You can just send us as a tweet, send it to us as a tweet, and then I'll try to make sure that our doctor is going to answer the question as briefly as she possibly can. And we're going to try to see how we can keep the space for us at least for an hour. All right. So I'm just going to hand over to Dr. Ada. So Dr. Ada, please just briefly introduce yourself, what you do, and then we can start with the questions.
All right. My name is Dr. Maduagu Adana. I'm an optometrist by profession, an eye doctor. I manage Standard Optical Eye Clinic located in Lagos, Nigeria, with branches in Apapa and VI. And today, I'll be talking about a topic that is dear to me, glaucoma, and I can't wait to dive in. Thank you.
All right. Thank you very much. Okay. So I'm just going to go into it. Please, can you explain what glaucoma is and how it affects one's vision?
All right, thank you. But before I explain what glaucoma is, I want us to do like a little exercise, okay? Let's imagine if we lose our vision today. What would you miss the most? Will it be your family, your friends, the memories you've made? Or will it be your independency or being able to take care of yourself, working without fear? These are the things that can happen if glaucoma is left untreated, stroke managed. Glaucoma is the second leading cause of blindness worldwide. It's also the leading cause of permanent blindness, accounting for 8% of blindness in general. Glaucoma on itself is defined as a multifactorial chronic eye disease affecting the back of the eye, and in the back of the eye, it affects the optic nerve. The optic nerve connects the brain with the eyes and is important for image formation and how the eye interprets images. So the main cause of glaucoma is high intraocular pressures. Let's say the eye is a ball, and what keeps the ball in shape is the intraocular pressure. And the intraocular pressure is the fluid that is inside the eye. So this causes high intraocular pressure and causes the damage to the optic nerve, which connects to the brain. How does it affect the eyes? Usually, glaucoma has no symptoms in early stages, but for people with angle closure glaucoma, they always have sudden vision loss and also blurriness, pain, and it's often sudden. So there are different types of glaucoma. You have the primary open angle and the closed angle. But for the closed angle, patients always have sudden pain, vision loss, seeing halos, and also is always very painful. But for the primary open angle glaucoma, is always no early symptoms, but in advanced stages, patient presents with tunnel vision where they already have loss of peripheral vision. So that's why glaucoma is very unique, and that's why it is called the term the silent side stiller, because it affects the peripheral before the central. So you can imagine it doesn't show signs, it doesn't show symptoms. So, but when it happens, when the damage happens, it affects the temporal vision then before and leaves the central. So you might not know that damage due to glaucoma is occurring, except you come in for a routine eye check where we're not telling you that you have this, because when you come into the eye clinic, we test whether your eye intraocular pressures are normal, because there's a range. Normal intraocular pressure is between 10 to 21. And I have seen patients who come in for just a routine eye check and they have pressures as high as 40, as high as 50. And this causes damage to the optic nerve.
All right, thank you very much for that. Okay, so please, I just want to ask a brief question. When you say halos, like, what do you mean halos around the eyes? What does, can you just break that down for us, please?
So when patients come in presenting with halos, is when the pressures are very high. So when intraocular pressure of the eyes are very high, it causes kind of a blurry vision and light sensitivity. So if someone looks at a very bright light, they see kind of colors, halos around the light. So you might be seeing the light that is white, you might be seeing different colors because the pressures of the eyes are very high. And this only in angle closure kind of glaucoma that presents with that kind of symptom.
So, can I just ask another question? So, when it comes to the symptoms of glaucoma, I know there are usually three different types. So, please, can you just give common symptoms and just kind of briefly touch on the types of glaucoma?
Right, thank you. They are mainly there are different types of glaucoma, but the most common type is the primary angle glaucoma. And in this type, it's slow but progressive. It shows no symptoms, and the patient just comes in for a routine test, and you can always notify, oh, you're having high intraocular pressures and everything. But in the closed angle, you have where the patient presents with pain, redness, the eyes are headaches, and the halos are which are very spoken about, and that's the closed angle. But when you talk about the secondary, this is caused by an underlying diseases like hypertension, diabetes, high cholesterol levels, uveitis, post-surgical. So when you do maybe cataract surgery, you can have secondary type of glaucoma. Then you have couching. Couching is a type of surgical procedure which is traditional. You have it in the northern part of Nigeria where people that have cataract, instead of going to a hospital to do the surgery, they just go to a very traditional and it just manually just takes down the intraocular lenses, and this causes also secondary kind of glaucoma. And then you have normal tension glaucoma. Even though the pressures are normal, the patient still has glaucoma. There is the structural damage of the optic nerve, which I've spoken about. That's like in the back of the eye, in the retina, what connects the eye to the brain. So the pressures are normal, but there's a structural damage happening there. Then we also have congenital glaucoma, which is when kids are born with glaucoma, and this is very not common, it's rare, but it happens to 1 in 1,000, in 1 in 10,000 kids have this, and this is really you have to have going for, it's like an emergency case because the child is born with a lot of abnormalities in the eyes and has to go for a surgical correction of the anterior chamber angle and everything. So that is like an emergency case, and the ophthalmologist handles this kind of cases.
Thank you for that. So, one thing that really stood out for me was when you said in some parts of the north, like they actually go to traditional healers who actually make the condition worse. That's actually quite scary. So I just wanted to ask again. So how is glaucoma diagnosed, and how do we normally treat it? Because you said sometimes there are some underlying health issues that can actually make it worse. I know for diabetics, sometimes they might have it for decades. Like that's something that I had to I learned recently, where they say at a certain age you're meant to go for a glaucoma eye test, especially if someone is a diabetic. So I just want to know what are usually the symptoms that we can look out for? Because yes, I know it's usually called the sight sealer or killer, because it can just come out of nowhere and just somebody's sight just like somebody start losing their vision little by little. Or is there any way that it can just come abruptly like that? So what are the symptoms that we need to look out for, and also what kind of advice can you give for people who have underlying health issues in terms of handling it, please?
All right, thank you. To diagnose if a patient has glaucoma, I'll give you a scenario. I have a patient coming working, and most patients with that coming don't present like, oh, I have glaucoma. They're just coming in for another thing that is unrelated to being a glaucoma patient. A patient in typical clinical setting, I have a patient working in mostly when they are above 40, because when you're above 40, you need reading glasses. They walk in like, oh, I'm not seeing clear at near, which is abnormal. When you're above 40, you have presbyopia. You need the aid of reading glasses to help you see at near. But during examination, we check the eye pressure. If the eye pressures are high above the normal pressure between 10 to 21, you notify them that high intraocular pressure is a risk factor for glaucoma. We also do what they call the fundoscopy, where we check the back of the eye, the retina, and on that retina is where we have the optic nerve head. We check for signs, whether is there nasalization of vessels. So if we see these signs of nasalization of vessels, we tell you, oh, this is not normal. You need to do further testing, like maybe the CVF test and the OCT test, which helps us check the visual field of the patient. Then if that comes back and it's okay, we're also okay. We have to now check the cornea. The cornea contributes a certain amount of pressure to the eye pressure. So either it reduces the eye pressure or increases the eye pressure. So a person comes into the clinic, okay, mostly in normal tension glaucoma. The patient comes into the clinic and the patient's eye pressures are 10. Fine, it's normal pressure. But you check when you do the fundoscopy, where if you have gone for a typical eye test, where the doctor switches off the light and comes so close to you, holding a handheld equipment. The doctor is looking at the back of the eye, where's the retina. The patient has low pressure, but when the patient doctor looks at the back of the eye, the doctor sees that this patient has the nasalization of vessels, and there's like other things we look out for: thinning of the retinal rim and sharpening bends of some vessels, and also bionetting. These are literally signs we look out for to say that this patient has glaucoma. The normal pressure is low, but now they are nasalization vessels. We now say, okay, you have to now go for an OCT to know whether is it normal for you or is it abnormal. Sometimes myopic patients have signs that they might have glaucoma, but when we send them for further testing like the pachymetry, where we check for the corneal thickness to know the contributing factor the cornea contributes, or either in a negative form or a positive form. So when you send the patient to do a pachymetry, the patient now with like in 10 um intraocular pressure goes for this pachymetry test. It can either come with a corrective factor of -4, or some people go as high as +5. So if you go for an intraocular test and we test and you have a pressure of 10, and you go for a pachymetry result and they're like, you need to add 5 to your intraocular pressure to know the exact amount of intraocular pressure you have. So when someone comes in and says you have a normal tension, you have normal pressures, but I'm seeing structural damage when I look at your optic nerve, because of your cornea is adding a +5, so making your intraocular pressure now 15, which is higher. So I have cases when patients come in and they have intraocular pressures of 15, but when you add a corrective factor what the cornea is contributing to the eye pressure, it takes it to as high as 20, 21, which is at the higher limit of normal intraocular pressures. So you check for the intraocular pressure, you check for the cupping of the optic nerve, you check for the visual field defect in the OCT and the CVF, and you also check for the corneal contribution of to the intraocular pressures. This will help you diagnose whether the patient is a glaucoma patient or a glaucoma suspect. For glaucoma suspect, it's always advisable to always come in at least 3 months to compare. So when you go for an OCT test, that serves as a tentative baseline. So you go for this test. And when you come back in next 3 months or next 6 months, depending on your eye care professional, the person tells you, okay, we'll not compare. Because I said that glaucoma is progressive, it's chronic. So if you come in for an eye check on maybe next 6 months and I compare, your pressures are still fine, but and I tell you to repeat your CVS result, and I can see that because these are quantitative, they are number basis. And so when there is a decrease in the number, it tells us that something is happening there. And I'm like, okay, please, oh, there is still a seeping of, there's a thinning of these optic nerve vessels. So there's something happening there, and we're still querying, oh, you're a glaucoma suspect. But if you come in like maybe a year after and there's a further depreciation of this, we know that you have glaucoma, and we start you right on the desired intraocular pressure medications to lower down the IOP. I hope I've not confused you people.
Okay, so I think you have to break down some of the terms that you mentioned, like OTC scan. Like, can you just kind of give a brief explanation of what that is, and then maybe some of the tests that you mentioned, and even the numbers. Like, what do you think is the healthy range when it comes to the eye pressure numbers? Like, what is a good range? I know from over 40 is basically a danger zone. So, like, just kind of break down what OTC scan is, and also what is a healthy range for the eye pressure.
All right. The normal eye pressure range is between 10 to 21. But I told you that in some my clinical studies and activity, I've seen patients with 50, 60, 30s intraocular pressure. But in normal pressure is between 10 to 21. An OCT scan is like a 3D scan of the retina. So it gives us, it is more detailed. When something is 3D, it's more detailed. It tells us, is there any structural damage? Glaucoma affects patients structural and functional. And in glaucoma, that's why glaucoma shows no early symptoms, because structural happens before functional. In functional, that's where the loss is visible, where there is peripheral vision loss and there's tunnel vision. That's so. But in glaucoma, there's a structural before a functional loss. But they go hand in hand, but the structural happens before the functional. So most of the tests we send patients for help us to check the structural vision loss, mostly the OCT scan. And these tests, they're always repeatedly at least once in a year, because they help us to check the progression of the disease. It helps us help us to check whether the management we put on the patient is it proper for the patient. Because when we repeat the OCT scan, we hope and pray that it's always equal and it's always the same, it's stabilized. Because if you repeat the OCT scan and there's a further damage in the result, it shows that the medication the patient is on has to be adjusted. That's why patients have to adhere to their appointment and their follow-up given by the optometrist or the ophthalmologist.
Right. Okay. Thank you very much for that. Thank you so much for breaking that down, Dr. Ada. Okay, so I just want to ask, are there any lifestyle changes or precautions that can help prevent glaucoma or even slow its progression?
So there's no known previous to okay, you there's no way to prevent glaucoma. It's only management. And sometimes lifestyle changes are always very important, like avoiding smoking, alcohol, exercise, diet, keep good healthy blood pressures, sugar level, and lipid, because the studies have shown to relate it to increase risk factor of developing glaucoma. And being African is also a risk factor. Aging is also a risk factor. Africans are 6 times higher at risk of developing glaucoma, and even 4 times higher in becoming blind due to glaucoma. So it's always important to always check in coming, prioritize your eye health by scheduling an eye care annually, comprehensive eye check with your optometrist or your ophthalmologist at least once a year. So this helps you to prevent your vision and to preserve your vision. So there's no known cure or no known act or way or lifestyle that can prevent you from having glaucoma if you already have glaucoma. So you just have to prevent and preserve your vision.
Thank you very much for clearing that up because when I was doing my research on glaucoma, I saw like on Google, like I saw an ad that said, "Oh, reverse your glaucoma symptoms. Take this herbal something 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 that can clear your vision in so time." And then I've even seen some people who say things like smoking igbo weed can actually help with glaucoma symptoms. And it seems like there's actually some research to it, but it doesn't. They say it doesn't cure glaucoma, but it can help alleviate the eye pressure. So I just want to ask, like in terms, like how you said there's really no cure for it, and really even in terms of management, it's just it's not. There's really no concrete evidence that proves that. But in terms of weed, I always see articles saying things like CBD can help with glaucoma, can help manage glaucoma, and most popular weed. I've even seen on some international comedy shows or programs where they'll be like, "Oh, get me my glaucoma is acting up. Get me some weed so I can calm it down." Something like that. I've seen things like that. So, do you really think it's misleading when we see information like that? Because even when you see push notifications and things, you always see things like, "Oh, weed can take care of glaucoma," or "Do this now to reverse your glaucoma." Like, do you think it's misleading information?
Totally is misleading information. I literally told a friend of mine that is presently a glaucoma patient that he always sends me things like, "Oh, a concussion, take this and save your sight." And I'm like, if you have glaucoma, be it in Nigeria, if you go to America, the signs and symptoms that you see in Nigeria is what we'll see abroad. So that's why sometimes I always advise patients, just if you have this disease, accept it. Accepting it on time is one way of preserving your vision. Because if you go around looking for what to take that will help, that will just totally say is a permanent cure, it won't work. Studies or research are ongoing to see looking for a permanent solution to it. But as of today, there's no permanent solution or permanent cure to glaucoma. So weed and all that, yes, studies have shown that weed reduces ocular pressure, but it is just for few hours and is no more effective than prescribed medications, which are first line management for glaucoma. So reducing it for just few hours can be compared of using your eye drops that will reduce it for at least 24 hours before you take the next drop. So it lacks long term efficacy. So it's not good to use weed to reduce your eye pressure. And also the side effects of mood alteration and personality and the whole effect of getting high and all that is not also going to be good to lower your intraocular pressure and also your lifestyle. So it's not a first line of treatment. So avoid weed. It can't help out.
Thank you so much. And especially with the kind of weed mixtures that we hear every day, I can imagine someone with glaucoma smoking Canadian loud. Like, that's just a huge recipe for disaster. Thank you very much for clearing that up. Okay, so you know how you said that there are some like there are some new treatments. There's a lot of research that has been done in looking for how to come up with a permanent solution for glaucoma. So can you just give us a little snippet on some of them, like if you know of any at the moment?
So the new emerging treatment for glaucoma is just around the intraocular pressure, and this intraocular pressure is formed by two ways: either the formation of aqueous humor or the outflow of aqueous humor, and it's either eye drops, laser, and surgery. So this is where the new treatments are formed, and it's just making to improve what we have on ground. So it improves the eye drops to make sure it's now more efficient, and also it helps to reduce the eye pressure. Then the laser treatment, some laser treatments have been improved whereby instead, because sometimes the aim of laser treatment is open up the clog pores that block the passage of this aqueous humor. So now it's more efficient by making sure that it doesn't have side effect, because most times there are some studies I've read whereby when they do laser surgeries for glaucoma patients, it makes up that angle. It kind of blocks the angle and closure in it, and it causes more damages. So now they've provided more better laser treatment options, whereby after it has shown more successful rates. So you do your laser treatment, it drops down the eye pressure lower to maximum, where that by it's not causing further damage to the optic nerve. And in surgery, they've improved, whereby they've created a passage. So they create a drainage whereby the aqueous humor can flow, whereby reducing the outflow of aqueous humor. So the aim of this treatment is just to make sure the intraocular pressures are as low as minimum, so they can reduce the damage caused to the optic nerve head.
All right, thank you very much. Okay, so let me just ask another quick question. So we know that there are like glaucoma affects people differently. So I noticed that when I was doing my own, just kind of looking up things on glaucoma, I noticed that there are specific ethnic groups and demographics that usually get affected. So I know that yes, definitely, if someone is over 40, they are meant to check, get their eyes checked and all of that. So can you just give a brief breakdown on the people that are mostly affected by glaucoma? Would you say it's mostly Black Africans, Asians? Because I've seen Japanese, African Americans, and Black people are usually mostly affected by glaucoma. And does it have anything to do with our genetic makeup, or does it have to do with maybe what our lifestyle? Like, how you said lifestyle doesn't really impact it. So, like, why do you think all these ethnic groups are usually the most affected by glaucoma?
Yeah, studies are still literally looking why Africans are more at risk compared to other parts of the world, but they've linked it to more of our food and more of genetic, as you mentioned. Then I already touched on intraocular pressure. Age is one of the risk factors for glaucoma. Then intraocular pressure is one of the major risk factor, but it's also controlled by the drugs and the surgery and laser treatment. Then you have hypertension, diabetes, high cholesterol, previous trauma. So you have people that have patients that come in and they just hit blunt trauma to the eyes and their pressure just shoot up. But when you give them eye pressure reducing drug, they go down to normal. So studies are still checking to find the link between Africans and glaucoma, but Africans are more at risk of developing glaucoma compared to other ethnicity.
All right, thank you very much. Okay, so I just want to ask another question again. So you know how you mentioned some underlying issues they can actually affect it. I know for people who are hypertensive and diabetes, especially diabetes, because it's something that I actually have a personal experience with. So a family member of mine on stuff anyhow. So anyway, so I know for a fact that when they do, some people have glaucoma and cataracts together. And there's also misleading information that tells the person that is suffering, the person who is a diabetic, and the person has glaucoma and cataracts. And there's misleading information in that if you remove the cataract, if you remove the cataracts, that it can actually give the relieve a little bit of the glaucoma, and the person can get a little bit of their sights. Now, is that possible? Please, like, can you just if that's true, or if because I
Let me come in. I understand you. So last week I saw a patient come in and he already had full matured cataract, bilateral in two eyes. He also is a known glaucoma patient, and I had to properly educate him on this. Cataract affects the intraocular lenses of the eye, and it's also a normal aging process. But diabetic patients are at risk because of the influx of sugar causes cataract to increase and also causes the glaucoma to also progress faster. So now they have two eye diseases. But cataract affects the lens, and the lens is before the retina. And the retina is where glaucoma affects. And on the retina is where you have the optic nerve head. So now, to solve the solution for cataract, you have to surgically remove the matured intraocular lenses. If you remove the intraocular lenses, I'm trying to make sure I just come through and everybody understands this. So if you remove the intraocular lenses successfully by surgical means, and cataract surgery is 90% successful. So you do this, you remove the surgery, the intraocular pressure, and you put in an artificial lens, and the patient sees. In a normal patient that doesn't have glaucoma, if you successfully remove the intraocular lenses, the patient will see perfectly. But now the patient has glaucoma, and mostly if the patient's glaucoma is so advanced whereby the patient already has lost more of the optic nerve head due to glaucoma and is now maybe in advanced stages and has tunnel vision, or even maybe blind, because sometimes patients that have glaucoma and cataract come to the eye clinic at advanced stage. We now have to advise you, if you do the cataract surgery, you have 50, it's 50-50. We don't know, because now we can't see the back of the eye because the lens is blocking the retina. We don't know the stage at which the glaucoma is at. And I've already mentioned that glaucoma, loss to glaucoma, is irreversible, is permanent. So we can't do anything there. So if you are totally blind in that eye due to glaucoma, and even if you have cataract that we can see, and we remove the cataract and you're already blinded by the glaucoma, that means we can't help your situation. But if you don't have glaucoma and we successfully remove the cataract, you can literally see. So it's a very dicey case in when the person has glaucoma and has cataract. And most patients that come presenting to the eye clinic are already in advanced stage. It really breaks my heart when people come in. Last week, if I said, a patient came in, cataract and glaucoma, and the pressures were as high as 30 in both eyes, and also full matured cataract. So the tendency is that even if we remove the cataract in the eyes, that the patient might not see is there. And you now have to advise the patient that, see, oh, if I remove the cataract, you might be blind. And because your damage is for a patient to come in with high intraocular pressures constantly, that means the damage has been constantly there over a long period of time. So that's why I always advise patient, please check your eye pressures. Don't come in when it's late, because that cataract patient, before it becomes fully matured, sees early symptoms of cloudy vision. And this cloudy vision becomes progressive, and it reduces when it becomes thicker and denser. It reduces the vision. But you see Nigerian patients coming in when they are not seeing again. And by that time, we can't see the health, we can't assess the health capacity of the retina. And it's very dicey. And we now have to start explaining and educating, because sometimes we now take out the cataract and the patient is like, you people have made me blind. But you came in blinded from glaucoma. So we always have to educate the patient. Do you want to take the risk? Because sometimes when we even take out the cataract, some people are lucky that the glaucoma has tunnel vision is there, and they just manage it, and they have to adhere to their glaucoma drugs to preserve what is left.
Thank you so much for giving us just breaking everything down. Okay, so I just want to just take questions, because Dr. Ada has answered all the questions that I have. So I'm just going to take some of the questions that some of our listeners have dropped. So from Happy Bird, he asks, how about pre-diabetics? Is the risk of glaucoma in pre-diabetics reversible, since the pre-diabetic stage is said to be easier to reverse?
So it's when a diabetic patient has a high inflow of sugar level, it affects the eye. I always tell diabetic patients, when your sugar levels are high, your eyes are literally affected. It causes blurry vision. But during that period of when your levels are high, it might have caused a bit of damage which you can't see, because I spoke about the structural damage due to glaucoma. So even if it goes down, it's always advisable to schedule an eye care visitation or appointment with your optometrist or your ophthalmologist to confirm that, okay, your sugar did not affect the optic nerve. And even if it affected it, to always monitor it, because glaucoma patients are always advised, or even diabetic patients are also advised, always schedule an eye care appointment with their optometrist or ophthalmologist to always monitor any changes due to uncontrolled sugar levels. So even if it might reduce when your sugar levels are back to normal, definitely it's not so hiked and so peaked for a very long time. It should not cause a long standing glaucoma damage, but it's always advisable to always come in for an eye check, because what can happen to A might be different from what will happen to B, because I've seen patients where coming just a small spike causes scotoma whereby there's visible damage loss in that patient. So you just have to always come in when your sugar is high, just come in, book an eye test appointment with your optometrist or your ophthalmologist.
Thank you very much, doctor. Okay, so someone asked a question that you've actually answered previously, and that's Nwa Odum. What causes pressure to the eye? I know you've already talked about it, but can you just give like a brief breakdown of what it is so that I can read the other questions that we have?
So there's no known straight point that causes, oh, this causes intraocular pressure, but just to their structural things, mostly the angle. When the angle is either closed, or when there's increase in formation of aqueous humor, or there's poor outflow of this aqueous humor, this causes increased buildup of the pressure in the eye. So there's no known this, but it's mostly on the outflow of the aqueous humor or the formation of the aqueous humor.
All right, thank you very much. Okay, so Happy Bird asks another question. Does regular squinting add pressure to the eye?
Regular squinting is literally telling you need to visit your optometrist. You need glasses. Whenever I see anybody squinting, it's just literally telling you for you to squint, you're cutting out peripheral rays so you can focus, images can focus on the retinal. So I'll advise that patient to visit the optometrist to get glasses. The person needs glasses, and it will not increase the pressure, but you need to also stop squinting, because when you squint, you're trying to see better, you're trying to improve your vision. So the person needs to book an eye appointment with me. So please enter my DMs. Thank you. Hello. Hello.
Um, okay. Sorry about that. I had a little network issue. So I'm just going to add Dr. Ada. Just give me a few seconds. So I've sent you a request, Dr. Ada. Please accept. Okay, please, so everyone listening, please don't forget you can send in your questions. You can just add them as comments at One Wellness NG, and Dr. Ada is going to answer them as okay, yes. So now she's now a co-host. Sorry about that. That was a network issue on my
All
end.
right. All right.
So please, yeah.
So I was saying that squinting literally says that the person has underlying refractive error. Refractive error is whereby the patient needs corrective glasses to help improve vision. When a patient squints, it mentions that it helps to cut peripheral rays so the patient can images can focus well on the on the retinal. So I'll advise a patient to book an eye care appointment with me, slide into my DM so we can get you needed refractive glasses to help you see better. And it does not increase pressure. But if your pressures are high, that means they're high. But squinting will not increase your pressure. Thank you.
All right. Okay. Thank you very much. Okay. So what foods can we avoid if what foods someone who suffers from glaucoma, what foods should they avoid?
People that have glaucoma should eat healthy. And healthy foods include leafy foods, foods that are high in zinc, vitamins A, vitamin C, so carrot, apple, fish, omega 3, And also supplements. There are good eye supplements that are good for glaucoma patients. We have the Lipotride, Optic Nerve, which is really good for glaucoma patients, which I prescribe to my glaucoma patients, that they use it with their topical eye drops, lowering eye drops. So eat healthy and eat more grains.
All right, thank you. And then I also noticed that when I was reading up about it, that a lot of things can like trigger or increase someone's eye pressure. Like I've seen something like caffeine, ginger, basically anything that has like energy, like stimulants. Yes, stimulants. That's what I was looking for. Anything that contains stimulants that someone with glaucoma should just avoid it totally, or maybe limit it
Yes, that's
depending
why
on the level it's at.
That's why I already advise on healthy lifestyle changes. Avoid smoking, caffeinated drinks, alcohol, exercise, diet, maintain good healthy blood pressure, sugar levels, and lipid levels. Avoid steroids too. Avoid steroids because all this affects causes secondary type of glaucoma. So healthy lifestyle changes are very important to keep your eye health healthy. So yeah.
All right. Thank you so much, Dr. Ada, and also thank you to everyone who has been listening in. So please, if you have any questions, please just kindly comment, or if you want to speak, please let us know. If anyone has any contributions, if anyone has any questions, just please kindly indicate so that I can let you speak. If no one has any questions, then I think I'll have to kind of round up. Okay, so someone has dropped a comment. Just give me
All right.
a few
Before we go,
seconds. Okay, so yeah.
before we go, I wanted to just list like if your tips on to patients who have glaucoma. So before we round up, I'll just give up tips on to leave it for glaucoma patients. So I will take on the
Yeah,
question
sure, no
first before I
problem.
do that. I thought we would just round up.
Okay. Yeah. So someone is sending in a request, and then okay, so basically the only comment we got right now was Happy Bird saying some basically saying coffee, but it's only once in a while. So do you think that maybe like he should stop taking coffee if he's at risk, or like what advice do you have for Happy Bird?
You should just stop it. Like if it's a risk, you should stop it. So because sometimes people the caffeine intake can really affect the eye and increase of the eye pressure. So it's advisable to him for him to stop it if it's at risk. Mostly when he has positive family history. So you should.
Okay, yes, yeah, you mentioned something. Okay, so Chisom, please, you can speak. You have the floor.
Hello, can anyone hear me?
Yes, I can hear you.
Yeah.
We can hear you.
Good evening, everyone. I've been listening for quite a while now. So my question is simple. Let's say a patient that has been a glaucoma patient that has gone blind as a result of glaucoma crisis. Is there still need to continue the routine eye drop and all that? Is this still necessary?
Sorry, did you say the patient has gone blind?
Yes.
Okay, he's totally blind.
Yes. Like the vision is kind of is not focused.
Is he seeing at all or he's totally blind?
Like I don't know the terminology which one is totally bad, but the thing is that
So when you're told that means he's not seeing, sometimes people there are types of blindness. There's low vision, there's totally when the person is just not seeing at all. So that's when if the person is not seeing at all, there's no light perception. Okay. Because sometimes people, even when the patient is blind, they always keep the person on the eye pressure drug when it's angle closure glaucoma, where it comes with pain, because sometimes the pressures are so high it can cause pain and headaches to the patient. So the ophthalmologist will say, please let's keep him on the eye pressure drugs to reduce the presenting complaint of pains and headache because the intraocular pressures are constantly high. So it now depends. That's why the patient has to come in to know is pressures within the normal limits first. If it's not causing any pain and the person is already blind, because glaucoma medication are pretty expensive. So you have to now know. You have to consult your eye care professional and ask the person that is managing the person to ask whether the person can take the drop off or not before you can take it off, because I don't know the patient's full history. So it's
uh,
advisable the person has to go and ask the managing optometrist or ophthalmologist. Thank you.
All right, thank you.
All right, thank you very much for that, Dr. Dan. Also, thank you very much, Chisom. Okay, so I also want to ask a question. So, Dr. Da, I know that genetics plays a role in in glaucoma. So I wanted to just ask, like, when it comes to genetics, like people who come from a family, maybe where if a parent is hypertensive and then you have another parent who is like diabetic and hypertensive. So like, when you're giving us your rounding advice, your tips and all of that, like, can you just give just a quick advice for people who come from families that have glaucoma tendencies or yes.
So I would advise the patient to, because most times when patients come in presenting and I say you're a glaucoma suspect, because whenever I'm doing a routine eye test in my clinic, I always advise when I'm taking the intraocular pressure, especially, I always say your pressures. I always tell you as I'm taking it, because if you have ever gone for an eye test, you know that when they are taking an intraocular pressure, it puffs a kind of air. So I'm telling you, I'm taking this intraocular pressure. I'm trying to measure your eye pressure. As your body has pressure, so does your eye have pressure. I'm also educating the patient. And high intraocular pressure is a risk factor for glaucoma. Glaucoma is a blinding disease. So as I'm taking the disease, I'm like, please relax. A puff of air is going to come out. Normal pressure, I'm telling the patient, normal pressure is between 10 to 21. As I'm taking the pressure, I'm telling the patient, okay, your pressure is 10, 10. And I'm like, your pressures are 10, 10, and it falls within the normal pressures between 10 to 21. So education is very key in management of any kind of diseases, be it hypertension, be it diabetes. So for diabetic patients and even glaucoma patients, chronic kind of disease, they're mostly hereditary. So it's advisable that you should always know. That is one of my tips in my rounding up statement. You should always know about these diseases. You should always take active steps, be intentional to avoid any further damages. Hypertension, diabetes, people and glaucoma present when it's always advanced, and by that time there's always damages that have occurred. So it's always important that you prioritize your eye health, prioritize your body health, book in for a routine eye test. Even if you don't have any complaint, just go. You want to run a general eye test, you want to run a general body test, you want to check your sugar level, you want to check your BP level, because of you have family history. So before I round up, my tips on my go-to is, if you have glaucoma, kindly just accept it, because a lot of people have glaucoma but they don't want to accept it. So they feel like, oh, if you don't accept it, you blame your village people when you go blind, and you feel like you didn't know that, oh, Dr. Ada said you are a glaucoma suspect, come in for an eye check at least 2 times in a year or 3 times in a year to let's monitor you to know, do you have glaucoma or don't you have glaucoma. And you have to also make sure that you speak out. Like, if you have glaucoma, tell your family members, I have glaucoma, please go and check your eye, because it's more is a risk factor. So you always have to speak out to make people know, because when you speak out to your family members that you have glaucoma, you can always preserve their eyesight by going blind due to glaucoma. And you also have to show up and be present. Follow up with your regular eye examination, because glaucoma can always change. It can, if you don't check it, you won't know whether your eye pressure drugs are really reducing the pressures. Because when you come in for routine eye checks, we check, is your eye pressure reducing, because that's the aim of putting your medication. Because if your medications are not working, we now take you to either try to take laser or the surgical management of glaucoma. Know your eye pressure. When you come into the eye clinic, always ask, what's my eye pressure? Does it fall within the normal limits of 10 to 21? Because we always know the lower the better. You want it to be fall between 10 to at least 16, because if it's on the higher limit, it's also a query. Glaucoma management is like, have to be closely supervised. So if you're a glaucoma managed patient, you have to stick to appointments, stick to prescribed medication, always apply your eye drops appropriately, and also adopt healthy lifestyle. Avoid smoking, avoid alcohol, exercise, diet, maintain good blood pressure, sugar levels, and cholesterol. Avoid steroids and adhere to your eye care appointment. Thank you so much, Ada, for having me, and thank you to everybody that listened to me today.